dear friends, colleagues, dear juniors who have now become like friends since I have been in ISAR, Central ISAR. It is an absolute honor to be given the opportunity to give the first Dhiraj Gada Oration. None of you will be knowing. I hope Dhiraj Gada sir will remember. The year was 2010. It was the annual conference of ISAR in Cochin. The managing committee member meeting of the then president ISAR Dhiraj Gada was going on. It was to start. I had just lost the election for managing committee member. I was very hopeful that I'll win because I had conducted the annual ISAR the time before, but I lost it. Before entering the door, I don't know if you remember or not, I told him, sir, I lost the election. Will you co-opt me? He said, yes, I'll co-opt you. And that was my beginning in ISAR as a managing committee member. And now it's 16 years since I have been in the ISAR managing committee. So, sir, it is an absolute honor and I cannot describe in words that I get to speak on the first Dhiraj Gada Oration. Thank you very much. So, my topic is cardinal sins in endometriosis. Now, centuries ago, can I have a pointer? Centuries ago, it was William Osler who said, he who knows gynecology knows endometriosis. Even after centuries, it is a major challenge of our times. It is the most destructive disease of the female body. Almost 10% women worldwide suffer from this. Almost 50% are infertile. Most of them suffer severe pain. 15–20% have severe depression and mental health issues. But the major thing is that the cost of endometriosis in terms of healthcare resources and the opportunity or the time lost is enormous and cannot be described. Achha, okay. So, it is an ancient disease. According to this book by Cameron Nizat, who is a very well-known person in endometriosis, it has been described almost 4,000 years back. And it is possible that a word called hysteria, when I was a postgraduate student, that term was still there, hysteria. It was being used to describe some women and mostly it was being thought of as of psychological origin. Now the word is not there. The youngsters must not have heard the word hysteria. Regularly there used to be a diagnosis, this girl is suffering from hysteria. It is possible that that was endometriosis. And if that is true, it is possibly one of the mass misdiagnosis and misjudgment and wrong thing that we have done against women for years and centuries. This is a picture of a woman who is undergoing fumigation for her hysteria. One of the most notable sufferers was Queen Victoria. She was known for her menstrual blues. She used to know how to cure it with marijuana and regular pregnancies at a very early age. And another well-known person was Marilyn Monroe. She was also very well known for her severe depression, multiple surgeries, abortions, and many people think that her death ultimately could be related to depression due to endometriosis. Now, pain is the most consistent symptom, has been pain almost everywhere people have described. Major parts of the body, of the pelvis is affected. In fact, almost all body parts have been described. And I have seen a very rare case of endometriosis of the episiotomy scar of a previous episiotomy. So, anywhere, anybody, in any place in the body, any organ can be involved. After pain, it is subfertility, reduced fecundity and infertility. So, there is no doubt that endometriosis, there is an association exists between endometriosis and fertility. And endometriosis creates an inflammatory pelvic milieu that could be toxic to oocytes, sperms, embryos. Physical sequelae of inflammatory scarring could be resulting in anatomical distortions, tubal dysfunction, occlusion, so many things, ovulatory dysfunction secondary to endometriosis and reduced ovarian reserve because of endometrioma. So, there is various ways in which almost all systems of reproduction can be harmed because of endometriosis. Can I have a water bottle? I just kept it here, but somebody took it, I think. So, there is a little lag between this one and that one. Anyway, treatment of endometriosis will raise complex questions for which there is no straight answer. And whatever I talk about today, you may not agree with me on all points. And therefore, how to manage the patient, all the possible paths will lead us in all different directions. Thank you. And it will be very misleading to us. We might not know the correct answer at all times, and we might not agree with each other at all times. But as physicians, primum non nocere, that is our fundamental principle. And deciding what not to do is more important than doing or deciding what to do. And that is the ethos of my oration today, which is the cardinal sins in endometriosis. I have listed some 7 or 8 ones. The point is what not to do, what not to understand, what not to think in endometriosis. That is the whole philosophy. So, cardinal sin number 1. Is it visible, the white one? The number 1, okay, I don't know. It's not visible over here. Anyway, so cardinal sin number 1, to think of endometriosis as one homogeneous disorder. Now, endometriotic lesions are microscopically, macroscopically, biochemically, genetically different. They have different aromatase activity, different progesterone levels of progesterone resistance, different gene expressions, and I believe each lesion is clonal, which means each lesion arises from one cell which has undergone genetic epigenetic changes. Pain levels do not correspond to lesion severity. Response to medical treatment for pain is different for different people. Some lesions will grow with painkillers, some with the drugs that you will give, some will not respond at all. There are some, it is supposed to be a estrogen dependent, but we know that they grow even after menopause, they grow even after retrograde menstruation has stopped with hysterectomy. So it is not one homogeneous disease. The old 100-year-old theory, that white one is not visible, okay. Theory of Sampson's theory of retrograde menstruation, that cannot be acceptable anymore. In fact, the theory that we should be taking up now is genetic epigenetic theory of endometriosis. We are not going to discuss that. Whoever is interested can read up about that. So endometriosis cannot be any longer considered as endometrium which is implanted outside the uterus. Consequence of series of genetic epigenetic incidences is what leads to endometriosis. Inherited or in utero imprinted incidents also increase the risk. So it is inherited, it is the person has to be predisposed, and they have to probably inherit some imprinted disorders right from the time of being in utero. And there is great heterogeneity in response to medical treatment, disease progression, recurrences, etc., etc. Therefore, we have to understand as gynecologists that giving blanket treatment to stop menses, because that is what we are doing in medical treatment, is too harsh a treatment, and that wouldn't be appropriate. So this is not visible, the cardinal sins, the top one. Anyway, sin number 2 is to think that imaging tests can give accurate diagnosis. Sorry, Sonal. For example, superficial implants are not possible by imaging. Positive predictive value of deep infiltrating lesions are at best 50 to 70%, and that too in high volume centers who do it every day. Ultrasound and MRI do give grading systems like Enzian, and now you have UBES, which is the ultrasound based system for endometriosis, but rarely do you get a report that tells you the level of difficulty during surgery. or who needs to be operated, or what are the actual problems, what is the depth, or what is the extent of the disease. So what we have to understand is that the clinical combination of symptoms, history, examination, imaging, laboratory data will enhance accuracy of diagnosis. It will suggest to us whether we should be doing a procedure or we should be postponing an intervention, and it will estimate the extent of necessary surgery, which is most important to a person who is doing surgery. And therefore, those of us who hope to become or who are endosurgeons, A, have to do their own ultrasounds at least, and B, have to be very well versed with MRI, and they have to be sitting with the MRI report and mapping their surgery. That is the only way you can become a surgeon who can plan to do a endometriosis surgery. Now, cardinal sin number 3, to give medical therapy or assisted reproductive technologies in scenarios that actually need surgical intervention. Now, here I may be treading on very controversial area, and many people may not agree with me, but so continuing medical treatment despite incomplete pain relief, the consequences are unnecessary suffering for the patient and the development of possibly more extensive and more severe endometriosis. Now, whether the patient is adolescent or whether she is infertile or she is fertile in having pain and other lesions, it's true for everything. And medical treatment in patient needing fertility. So these are wrong things that we will be doing if we are doing such intervention. Now, whether mostly for endometriosis associated infertility, there is so much debate about whether we should operate or not operate. Mostly people are shifting from operate to not operate. But endometriosis and surgery go together, because surgery gives a laparoscopy, number one, gives you an accurate diagnosis. It gives you the extent of damage. It gives you a endometriosis fertility index, which, as you all will be knowing, is the most important tool for us to give prognostication to our patients, so that we can guide you what are your chances of getting spontaneously pregnant, what are your chances of getting pregnant with IVF, IUI, etc. And for correction of pelvic anatomy, surgery is for pain relief, it is for large cysts, it's for acute emergencies. Still there is so much debate about whether we should be operating or not. Who needs surgery? At least for infertility, the guidelines, the ESHRE guidelines are very clear. The basic question, if they asked in women with endometriosis, is surgery effective to increase the chances of natural pregnancy? The answer was, of course, yes. But they recommended that decision to perform surgery should be guided by the presence or absence of pain, patient age, preferences, history of previous surgery, presence of other infertility factors, ovarian reserve, and estimated endometriosis fertility index. But please remember, to estimate fertility index, we need laparoscopy. So now I'll be showing you some of my own cases here and the videos, but I'm really sorry this is not working. Should I change the color? But I think it will get late. Anyway, maybe if you shut down the lights, it will come. Hello, can we do that? ये वाले light बंद कर सकते हैं? So this is a young girl. She is 19 years old, and she has huge multiple endometriomas, bilateral. Now here, of course, there is no question that you have to operate. I am talking size 15 centimeter, 20 centimeter, reaching up to umbilicus. So you have to operate. But another challenge is, after a good surgery, one also need to think how to do the long-term suppression in a 19-year-old girl. So here the surgeons need to recognize the extent of the disease before doing surgery. They have to estimate, they have to plan the surgery based on clinical data, imaging, and what are the patient's goals. और थोड़ा कम कर दीजिए ना, still not visible ना, दिख रहा है. Surgeons then need to decide whether they have the skills to perform the surgery effectively and safely, and if needed, to refer the patient or obtain help to provide complete surgical services. This is what we need to understand if we want to operate on patients. Surgery can be unexpectedly challenging. I have known of surgeons who have landed in real difficulty with just a endometrioma excision with so much bleeding that they have had to remove that ovary. And experience is necessary in order to recognize endometriosis, to perform excision without completion. So, here the problems are many. The major problem is after this surgery, how to give them long-term suppression. We will come to that in our next slides, and I may not have the time. But in this patient, she was my own patient for of 19 years only, and after doing a surgery for her, even including reconstruction of the ovaries, bilateral ovarian endometrioma, some excision of the ovarian cortex you have to do because it's so thinned out. After that, I put her on leuprolide and then on long-term oral contraceptive pill. I think she was with me for almost 2 years after surgery, but after that I lost her to follow-up, but she was reasonably all right. Of course, she has had very long-term problems. And also we have to understand that in patients like this, there is a role of fertility preservation. So one can seriously think in scenarios where it is fitting to think about ovarian cortical preservation, because 19 years when she will have her child is not known. Okay, and this is, I don't know if the video ran or not. Now this is a case of ruptured endometrioma, again a very young girl, and she came with an acute abdomen, and of course you have to operate on them, and you can't do much excision, but at least during this during acute emergencies, whatever can be done has to be done. Now this is another patient. This is going to be controversial. She is a 28-year-old, primary infertility of 2 years. First line investigation shows the following scan picture. I wish I had a this thing. Okay, her AMH was 2.4, male factor was normal, HSG was normal. I have shown this case in many forums, many discussions, and most ART specialists jump on me. Why do you want to operate this patient? The ultrasound shows clearly both the ovaries are stuck to each other, behind the uterus, displaced low down. One of them has an endometrioma. I showed you the, of course I will operate on her, at least A, to see if she is okay for IUI, because this patient is not going to conceive with IUI. There is total distortion of the tubo-ovarian relationship. But after a reasonably good surgery and the restoration of anatomy and clearing the tubes and creating a tubo-ovarian relationship both sides, there is a fair chance, if the patient's age permits, that you can leave her for a natural conception maybe for 6 months, 1 year, or she can conceive with an IUI immediately. You have to take a call about how much endometriosis you have left behind and things like that. But I know that many ART specialists will not agree with this, but with this kind of ultrasound picture, at least we don't do an IUI without knowing the tubo-ovarian status. You might take her up for IVF if you want. Now another patient, 5 centimeter endometrioma with bilateral hydrosalpinges. Of course you have to do a surgery. She is for IVF, so you have to do a surgery, you have to do proximal clipping, but surgical expertise is a must, because to remove this kind of tubes, you have to be sure whether you want to do a salpingectomy or you want to just do a proximal tubal block, whether you want to do a adhesiolysis or not of that other ovary which is stuck to the lateral pelvic wall. And this is a very nice endometrioma which is from one of the poles of the ovary, so I decided to do the cystectomy nicely and cleanly to the best of my capability. And of course I left the other ovary only by draining and leaving it and then taking her up for IVF. I am going to show you 2 images which are extreme examples. You may not agree with me. They are extreme examples of why sometimes, see, don't get me wrong, I am a laparoscopic surgeon, I am also a ART consultant, I am a jack of all trades, master of none, but I am not propagating that you should be operating or doing a diagnostic laparoscopy for them. Just giving an example, extreme example of what can be missed. You just can't do a tubo-ovarian relationship. The only way you can study that is by laparoscopy. There is no other way. For example, look at this image. One tube is stuck up over there. There is no way this patient is going to get pregnant with this tube and this ovary. Another, but not very clear, I hope, I don't know whether you can see it or not. The tubes are facing the liver and they are stuck there with adhesions. So both sides tubes are like that. I didn't have time to run the video. They can't possibly get pregnant otherwise. So, I'm really sorry now, this is not visible, no? Can you read? Shit, yeah. Because I made it in white color because, huh? I know, so because I put it with white. Do you think I can can you give me 1 minute to, okay. So, cardinal sin number 3 was not to operate when you should have operated. Cardinal sin number 4 is to operate when you should not have operated. So, let us take the example of this patient. She is just 21, unmarried, severe dysmenorrhea, gradually increasing, incapacitated almost 4-5 days every month, pelvic discomfort lasting many days the whole month. Ultrasound shows a 3 centimeter endometrioma on the right side and 2 and 1.2 centimeter endometrioma, essentially bilateral endometriomas within 1 to 3 centimeter sizes. There are subtle features of pelvic endometriosis and abdominal scan. I did not put up the picture. Now, she was advised surgery somewhere and she came for a second opinion. Will you operate? I don't think so. I don't think there will be any surgery at this time. If not surgery, how will you treat her? GnRH analog? Big question mark. We used to do that a lot earlier, but now it has been shown that in young girls at least, adolescent girls at least, there is a very great incidence of depression, suicidal tendencies, and so you cannot give GnRH analog to young girls for a long time. You shouldn't. I am still very fond of it. I give it max for 3 months. Sometimes maybe stretch it to 6 months, but I feel bad and I keep taking their mental health history, and then you have to do a add back. And with a long term oral pill, they might just pull a couple of years. But Dynogest now is in the market, and Dynogest now is considered as a first line drug for pain management, especially in young girls, those who don't need fertility at this time. But my personal experience between Dynogest and GnRH analog, both have pros and cons. We are not discussing that today, but I would have always preferred a GnRH analog. I feel recurrence rate is less, although evidence says that with Dynogest the recurrence is little more or less. So these are difficult patients, but that is how you have to manage. And of course, your goal will be how to do symptom relief, how to suppress the and disease progression, and how to protect future fertility. And of course, if she doesn't respond to pain, it's really bad, you might consider surgery, and at the time of surgery, that is the best chance for her to avoid further surgeries. Now, this is another patient, inadequate unskilled surgery in a patient who needs ART. She is 26 years old, severe grade 4, bilateral endometriomas. She was operated once 6 months back when I saw her. And when I saw her, this was the scenario on both the sides. The endometriomas had filled in again, and there were gross hydrosalpinges on both sides. Another patient, 31 years old, primary infertility, 1 year, AMH is less than 1, no male factor. She is for IVF. Am I going to operate? I don't think so. She should be undergoing emergency IVF or whatever, at least an IVF, so she is not for surgery. Now, here is another case which again might be controversial. She is a 30-year-old primary infertility of 5 years. Her baseline investigations are normal. Her AMH is 1.89. Male factor is not there. She has come to me for IUI. Essentially, she has been diagnosed as unexplained infertility and sent to me for IUI. When I do a scan, I find features of subtle pelvic endometriosis, as I have shown in the ultrasound. And so I will take her up for laparoscopy, at least for an endometriosis fertility index, at least to see her pelvic anatomy. Without that, I wouldn't subject her to an IUI, because do you think this patient with completely obliterated pouch of Douglas, both ovaries completely fixed and surrounded by adhesions in the lateral pelvic wall, no TO relationship to talk about, is she going to get pregnant with IUI? She is not. But the question that I want to ask here is, so I take this patient for IVF, but does that mean that I should be doing an extensive adhesiolysis? Should I be doing an extensive rectovaginal surgery here to clear her pouch of Douglas before doing an IVF? Now, that is one big question. I don't know if there are endosurgeons here, but if there are, probably this is a very big question that needs to be asked, whether we should be operating for extensive clearance surgery in the pelvis and rectovagina for this patient. She is for IVF, before IVF, since I have taken her up. Correct, but many endosurgeons believe that clearing up the pelvis and the rectovaginal pouch gives them a fair chance of a natural pregnancy. Now, sin number 5, quality of infertility, endometriosis surgery is decreasing. To not accept that surgical skill is the ultimate yardstick, that would definitely be a sin, because the first surgery is make or break surgery. Look at this patient. Again, this is going to be controversial. She is married for 32 years, 32-year woman, married for 6 years. AMH is 1.69, HSG is normal, male factor is normal. Transvaginal sonography shows bilateral multiple endometriomas. I do my own transvaginal scans. That is how I have put up all the pictures. So, she is for IVF, of course, but is she for surgery? Both sides 3 to 4 small endometriomas, 0.5 centimeter, 1 centimeter, at least 4 to 5 endometriomas on both sides. Now again, agree with me or not, I did take her up for surgery to clear it up, because I couldn't imagine doing a pickup with those kind of endometriosis. So balancing IVF and infertility surgery can be very difficult, because there are so many variables. And here I want to draw your attention to another theoretical fact about the impact of endometrioma, because endometriosis has different phenotypes. Having an endometrioma creates different problems where pregnancy and fertility is concerned. So there are many variables here. Let me just forward this a bit. So whether the endometrioma is unilateral, bilateral, what is the size of the endometrioma, for how long the endometrioma has been there. These are very important variables to decide how it will impact their IVF outcome, impact their infertility. There are many studies that suggest that the presence of omas does not significantly impact ovarian response unless the size is more than 3 to 4 centimeters. Detrimental effects of endometriomas over time may be unremarkable for smaller cysts, but it could be significant for larger cysts, because larger cysts push the cortex and there can be microscopical changes in the cortex, in the existing primordial follicles that we are so afraid when we are doing surgery. So they contain a plethora of potentially toxic agents. The long lasting diffusion of these substances into the ovarian stroma may progressively damage and diminish the primordial follicular pool. So the fibrosis that is around the endometrioma cyst wall, that can damage itself. The diffusion of material, toxic material from the endometrioma into the normal cortex can certainly damage the primordial pool and reduce the ovarian ovarian reserve. So for this patient I did do a surgery, and to the best of my capability, no electric current was used, only with pitricin. The small endometriomas, to the best of our visibility, were drained, and the cyst walls majority were removed without using any cautery whatsoever, and then I took her up for IVF. She is not pregnant as of now, but I have taken her up for IVF. Now, the impact of ovarian endometriosis, we have to understand that endometrioma per se also damages the ovarian reserve and also might damage the remaining follicular pool in the ovary. And surgery definitely has been shown to damage the ovarian reserve. But how is that measured? That is measured with the AMH level. We have no other means of measuring that you have done a surgery, AMH is down, sure. But many of the reports or the meta-analysis show that whether you operate or you don't operate, the results of the IVF outcomes are probably almost the same. So, and another thing we have to keep in mind, that conservative management of endometrioma can have some theoretical risks, that is risk of rupture, risk of developing cancer, follicular fluid contamination, infection, etc., etc. This is just to give an overview about endometriomas and how they are very different from generally having endometriosis, and which endometriomas have to be operated even if she is for IVF is like rapid growth of endometrioma, sonographic suspicion of malignancy, severe incapacitating pain, rupture, presence of hydrosalpinges, or very large size, or if it interferes with your egg collection. Now, cardinal sin number 6, there is nothing called complete excision of endometriosis. To believe in the dogma of complete excision, which so many endosurgeons believe, is probably not right and not supported by the scientific data that we have. So it has been shown that there are microscopic endometriosis nests in the bowel wall in a distance, there are in the lymph nodes, in the peritoneum, explaining similar recurrence rates after a proper extensive surgery. We have to understand the lesion belongs to endometriosis, that is the disease. The fibrosis belongs to the patient. So we have to make a judgment, personal judgment, the surgeon has to make on experience and personal skill to balance the completeness of excision and to leave some amount of fibrosis behind. That is a judgment that the surgeon has to take and we have to do, because it is also unclear whether the excision of large areas of peritoneum, that butterfly excision of peritoneum in stage 1, stage 2 endometriosis, whether that improves fertility and whether that should be that should be done or it should be abandoned. So there is nothing called complete excision. You cannot excise endometriosis completely is what most experts believe. Finally, the shoe shop syndrome. Shoe shop syndrome means that all shoe shops will sell shoes, but they can only sell shoes which belong to their own shop. You cannot sell shoe which is from another shop. So it means that if the only tool you have is a hammer, you tend to find every problem as to the nail, to be the nail. So we have to keep that in mind. If we do not have this tool to do this, we need to find another shop. That is the whole point. Endometriosis management, like it or not, requires expertise in pain management, requires management for infertility, medical therapy and surgery. So one has to have all those, or one has to sell shoes from multiple shops. And the final sin of endometriosis is the total absence of quality control in surgery, total absence of training and guidance in surgery. That is the major issue that I would say we all face, all the youngsters who are passing out, who are coming up in life are facing. So there are a lot of limitations of evidence-based medicine surgery. You can't have RCTs for surgery. So you have to depend on experience-based medicine also. The importance of incorporating experience has to be done, and we have to have people who will guide us. Have a look at these videos. These are my last few slides.
It doesn't matter for everyone.
Sound thoda dijiye to.
It doesn't matter whether you're a basketball player,
Sound.
a tennis player, a gymnast, or a bridge player.
Can you hear?
My bridge coach, Sharon Osberg, says there are more pictures of the back of her
So
head
everybody needs a
than
coach.
anyone else is in the world.
I don't know. I can talk about myself.
There you go.
I did not get the opportunity to stand and watch anybody operate.
That's how we improve.
I did not get the opportunity for somebody to hold my hands and teach me
Because I received so many
that this is how this surgery has to be done.
One that comes to mind is to have a coach. Our board member in 2002, John Doerr, said, "You need a coach." And I said, "Well, I don't need a coach. I'm an established CEO. Why do I need a coach? Is something wrong?" He said, "No, you need a coach. Everybody needs a coach." So Bill Campbell became my coach and served Google very well. Every famous athlete, every famous performer
Can you hear?
has somebody who's a coach.
So anyway, he's the CEO of Google, and even he was told that you need a coach. So I was lucky in my life. My father, being a gastrointestinal surgeon, he gave me, he stood with me and even washed up with me for many surgeries and taught me the basic principles of surgery, even if not gynecological surgery. And for that I am grateful. I can remember two things that he taught me. Number one, if you put a scalpel on any patient, they will keep coming back to you always, even if they had a headache. So make sure that the patient tells you that he or she wants you to operate. And second thing was, that a patient and their family can give you no greater honor than allowing you to operate on them. So you must be worthy of that honor. But we all need somebody. We have to have this whole, culture of having mentorship. It is there abroad in many countries. Unfortunately, we don't have mentorship thoughts at all. And even if we have, like, let's say, I would say I want to teach some people, you have to have willing mentees. We don't have willing mentees. Most students, when they pass out from postgraduate, they feel, I may be wrong, but they feel they know most of the surgery and they don't need. Anyway, so we need to have that. This is exactly why you need a mentor. On a lighter note, have you heard about anti-mentor?
That's why I follow people I call anti-mentors. People who do exactly the wrong thing, whose instincts seem to be just completely bass-ackwards, who always seem to step on the rake. There's plenty of examples around. They're easy to find thanks to social media, where their exploits get shared, sometimes even by them, on purpose, especially on Twitter. But there's plenty of them here too. I follow a lot of them. There's more to this than schadenfreude, the joy of watching others fail. It's a great education, a chance to learn from others' mistakes, a ready online catalog.
So the whole thought, ethos is, I remember our professors and all telling us it's very important to watch bad surgeons, to know what not to do in surgery. So that is the whole concept of an anti-mentor. So you should maybe have that also. Okay, so the key takeaways, our understanding of etiopathogenesis of endometriosis has undergone a paradigm shift. We need to understand this disease and renew and update our knowledge on this. There is no non-invasive test to confirm presence and extent of endometriosis. Surgery is an integral part of diagnosis, scoring and treatment of endometriosis. However, surgical skill is paramount and we need to keep that in mind. We need more mentors and more willing mentees. And I think there are in many countries to have a system to accredit and mandate surgical skills. So there should be some mandation that, okay, this person is qualified to do this surgery, not just, have a degree, but there should be regular updated. So thank you very much. And this final editorial caught my eye. There is no doubt that we practice evidence-based medicine. In God we trust, all others must bring data. But this was a very recent fertility sterility editorial that said common sense versus data, which we should use to guide, in our practice decision. I think this is most true in endometriosis, where we have to use common sense more than what data says to practice our cases. Thank you very much.